Okay, so I will quickly go over the function of the rotator cuff because we have been speaking about this a lot today, but of course it dynamically maintains the center of rotation of the glenohumeral joint, resists against the upward vector of the deltoid. Tears of the rotator cuff lead to eccentric omotritis. A lot of joint preserving procedures are described in a situation of a non-repairable cuff tear, partial repair, biological augmentation, implantation of a subacromial balloon or any other biological or non-biological implant, superior capsular reconstructions and tendon transfers. But of course, this is debatable as long as the articular cartilage of the glenohumeral joint is preserved. Otherwise, we need to talk about reverse shoulder arthroplasties. What do irreparable subscapularis tendon tears result in? Anterior posterior imbalance of the forescapula in the transverse plane, pain and loss of strength in internal rotation. And when a concomitant supraspinatus tendon deficiency occurs, then there's vertical imbalance of the glenohumeral joint and anterior superior migration of the humeral head, anterior shoulder pain with dysfunction, weakness, anterior instability, and leading to pseudopelatic shoulder in the end. So for anterior cuff insufficiencies, a few tendon transfers have been described so far, including the pectoralis minor, the pectoralis major, and the Latissimus dorsi, as nicely exposed in those drawings from our friends. The pec major transfer, so the idea of this lecture is not to say if one is better than the other, but I'm trying to explain what the possibilities are and the history about it. So it started with the transfer of the sternal head of the pec major. It was first described deep to the clavicular head and for isolated irreparable subscap tears. Gerber's team published about their long-term results with a mean follow-up of 20 years on 22 patients that they followed up for 19.7 years. They improved their constant score, the SSV, and all patients rated excellent results, good to excellent results, but active internal rotation and external rotation decreased significantly with time. Resch modified this transfer by putting it behind the conjoint tendon, and Moroder published another result with 20 years of follow-up, saying that most of them improved, the constant score improved and remained improved. But the strength improvement had returned to preoperative level at the long follow-up. So did the improvement of the range of motion. And other studies basically published the same thing. So to summarize the pec major transfer, it provides the best results for the patients with isolated irreparable subscap tears in the absence of an anterior instability or static anterior subluxation, but in the long term, you will lose again the range of motion and the strength that you may have recovered initially. What is debatable about this transfer is that the line of pull is coming from the front. And so the ideal transfer should come from the back of the shoulder, well, at least the back of the thorax. So the latissimus should recreate a better line of pull, line of action of the subscap because it is along the fossa of the subscap. So this is why the idea about using the latissimus came, and the latissimus dorsi transfer is well-known transfers. Philippe and Bassem have spoken about it, and we have heard about it, and it was described for ER palsies, and then it was described for posterior irreparable cuff tears. And Bassem described in a feasibility study the transfer for irreparable subscapularis lesions. And then it requires some awareness for the surrounding nerves. Anyways, is it applicable to pseudoparalytic shoulders? A lot of techniques exist. We can debate about this, and I would like to know Jean's opinion because the problem of the latissimus is that you need to release its adhesions from the scapula in order to really be able to bring it on the lesser tuberosity. And I think that a an approach, smaller approach at least at the level of the scapula is important in order to really be able to move the muscle. So I will quickly go to a video, but maybe this is important because you have to think about the nerves, typically the radial nerve and the axillary nerve, when you're going to bring the latissimus from its very inferior insertion at the inferior part of the lesser tuberosity to higher on the lesser tuberosity. So this is an important aspect also, as I was telling you before. You have to release it from the tip of the scapula. And those images are taken from a video that I will show you right now. I'm sorry about the quality, and JD was telling me that I should maybe work on the quality of my my instruments in the OR, but so we're here facing a massive rotatory cuff tear that was repairable on the posterior superior cuff, but not repairable at the level of the subscap. So the way we do it in Annecy is that we like to harvest the tendon arthroscopically. Jean described an all arthroscopic technique to transfer the latissimus and the conjugate and the teres major to the posterior superior cuff tear. So we go very low below the insertion of the pec to find the insertion of the latissimus. And this is the dissection of the upper border of the latissimus. And then once we have been able to landmark the latissimus, then we can use this retractor under the conjoint tendon, but you have to pay attention to the radial nerve, and then you will go and find the inferior border of the latissimus and mark the inferior border of the latissimus, and then you detach the latissimus from the lesser tuberosity, paying attention not to detach the teres major, which is something that I think Jean does differently because he takes both. And then once you have detached the tendon from the lesser tuberosity, you have to elevate it from the teres major. And another important aspect is that you need to release the adhesions between the latissimus and the triceps. So you have to move to the inferior border of the latissimus and detach the expansion to the long head of the triceps. You have to be careful when you do that because the radial nerve is really close typically, and more particularly the motor branch to the long head of the triceps. So this is the expansion to the triceps. We can see that very easily when we do it open. It's a little bit more difficult arthroscopically, and sometimes it's not very satisfied. It's very satisfactory to do it all arthroscopically. And then you really need to push your latissimus back to the back of the shoulder in order to release it from the scapula. I think this is important because I've been limited in the past when I did not release it from its scapular insertion. So now I really like to do that incision away from the axillary fold in order to limit the risk of infection. And then we use this urinary catheter to keep the correct trajectory, typically in relation to the nerves, and then we will bring the transfer back to its anterior insertion. And so it's going to be posterior to the radial nerve still, and lateral to the axillary nerve. We prepare the fixation zone, which is the lesser tuberosity. And then what is also important, and I learned that from Jean Cany, I think it's important to place at least 3 anchors, because if you only place 2 anchors, typically 2 knotless anchors, then there is a risk of a windshield wipers effect. And so we use those 2 knotless anchors to place the tendon on the footprint. And then once you have placed a 3rd anchor, which is a little bit more superior and a little bit more medial, then you can attach the latissimus also with that 3rd point of fixation. And that makes it flat on the lesser tuberosity and maybe with a better chances of healing on the lesser tuberosity. So typically we use a lasso loop technique to place this medial and superior anchor on top of the Latissimus dorsi. The fact that we have this short open approach is also easier to place the sutures, very strong sutures on the Latissimus dorsi. And this is that patient 1 year afterwards. So it's a pity I don't have the pre-operative video, so it doesn't really mean something for you to see that. But this patient typically was not pseudo-paralytic. He was just painful with a non-repairable subscap. And you can see on the video that he was not able to recover a full range of motion in internal rotation. And so this is also something that we need to speak about, but I don't think that you can transform a pseudo-paralytic shoulder, like a real pseudo-paralytic shoulder with limited anterior elevation, with a Latissimus dorsi transfer on the upper subscap. And you can control that they still work after a year by trying to ask the patient to do some adduction, and you can see that the Latissimus dorsi has a different course, but it's still effective. So in conclusion, the long-term outcome studies show satisfactory results for the pec major transfers, but only for isolated irreparable subscap tears and no static anterior subluxation. And the improvement in strength and range of motion of a long-term follow-up are limited. The Latissimus dorsi transfer is attractive, but we don't have a lot of peer-reviewed literature yet. There is a risk for nerve injuries, but you can control that. So far, the results seem satisfactory, but the question remains raised for real pseudo-paralytic shoulders with complete limited forward elevation. Thank you so much for your attention.